Hello again, and welcome to the topic on childbirth and newborn care, which spans the knowledge related to childbirth that is introduced in Visit 4, the last visit of pregnancy, Visits 5, A, B and C, which is the first week of life, and Visit 6, which is at 1 month. The learning objectives here are just to explain a little bit about the rationale for the interventions that we've included for newborn care and some of the evidence around newborns. Also to describe the visit timing and sequence of topics that are covered, and also the health practices that are included in the essential actions for newborn care. So in the last 2 decades, we've seen a really rapid progress in improvement of the survival of mothers, so around about 4.2% reduction in maternal mortality per year, and also in children after the neonatal period, we've seen around 3.4% reduction in child deaths per year. However, newborn survival has definitely lagged behind. We've only seen around 2.1% reduction per year. And progress for stillbirth reduction has been even slower, around 1% per year. Newborn deaths currently account for around about 44% of all deaths amongst children under the age of 5. New global targets have been set for ending preventable deaths of children under 5, and for newborns they have been agreed in the SDGs agenda. The under 5 target by 2035 was outlined in the document A Promise Renewed. It cannot be met if newborn deaths outlined in the Every Newborn Action Plan are not also addressed. The Every Newborn target is aiming for a national newborn mortality ratio of 12 per 1,000 births by 2030. This requires an annual rate reduction of 4.3% per year from the current annual reduction rate of 2.1%. The idea is to focus on the 29 high burden newborn mortality rate countries who will need to double their rates of progress at both national and subnational levels to ensure that the most vulnerable newborns and inequities are addressed. So given that newborn deaths make up around 44% of under 5 deaths globally, and in many countries it's more than 50%. For countries to meet their goals for the reduction, they must focus much more on saving newborn lives. The 3 main causes of newborn deaths are preterm birth, birth complications, and neonatal infections. And there is so much that can be done to prevent these conditions, but certainly over the last few decades, especially during the Millennium Development Goals era, we did not see the scaling up of interventions that would address newborn deaths. So in our timed and targeted counselling content, we've designed the schedule of visits and the activities of the visits to really address some of these. Prevention of these 3 forms of death involves improved health and nutrition of the mother, improved access to effective and quality health care from trained professional health staff during antenatal care, delivery and postnatal care, and also increases in knowledge and home-based practices and demand for health services by families and communities. Treatment is the responsibility of the healthcare services and not the village health worker. However, a village health worker plays a key role in ensuring the links to the health services and make sure that mothers and newborns are accessing treatment when they need to. They also have a key role in making referrals of newborns when they become sick, and conducting home visits and special care for any small or sickly infants or any highly vulnerable infants such as those that are HIV exposed. Because newborn infections and newborn illness is so hard to spot, especially if you have no prior experience such as being a mother, it is advised that the village health worker does active case seeking, and that's one of the reasons why we have 3 visits in the first week of life, because they can pick up in a timely manner when newborns become sick. So, looking at the current status of evidence around newborn care interventions, we have decided to include 3 specific interventions for the first week of life to strengthen our newborn care component. So the first one is we're going to include 3 postnatal visits for the first week of life. And as I mentioned just now, that's about active case finding. So we cannot leave it down to the mum and dad to detect when the newborn is sick. It's really important that you have a trained village health worker who is monitoring the health of the infant. Secondly, we're going to be training the village health worker very carefully on how to do a top-to-toe assessment of danger signs. We've also provided a series of video multimedia sources for this, because we really find that even though you teach them in theory, if a person has never seen a sick newborn, they really don't know what they're looking for. Those videos are available on small, low-resolution versions so that they can be uploaded to village health workers' telephones and played to the mother to help them to understand newborn danger signs as well. And then thirdly, we've included care of the small baby to include the community-based components of kangaroo mother care. There's also a lot of new evidence on the prevention of newborn sepsis using chlorhexidine treatment for the umbilical cord. So there was a pooled analysis of randomised controlled trials from Nepal, Bangladesh and Pakistan, and they were conducted using village health workers applying chlorhexidine solution to the cut cord within the first day or week of life. The combination of results showed that there was a 23% reduction in child mortality of those newborns that had received chlorhexidine, and there was a 68% reduction in serious cord infections. So the recommendation that resulted from that was that daily chlorhexidine application of a 4% solution should be put on the umbilical cord during the first week of life, especially those who are born at home or in settings with high neonatal mortality. Okay, so that's over 30 per 1,000 births. For all settings, including those in low neonatal settings, clean, dry cord care is recommended for newborns in health facilities. So use of chlorhexidine in these situations may be considered only to replace application of a harmful traditional substance, especially in Asia we see that as quite common. However, what we are recommending here is just to mention that to the mother, that no substance should be put on the umbilical cord unless it is chlorhexidine. So although that may not currently be the policy adopted by your country, we've left that recommendation in the curriculum. So, due to the high proportion of all newborn deaths which are in small babies, we've decided to include an extra session, despite the evidence being quite weak on what is the role of village health workers to support kangaroo mother care being carried out after discharge from the hospital or facility. Kangaroo mother care is typically practiced in a health facility, and those studies that have been done in health facilities, the evidence for this is very, very strong, but it has been slow to be applied in low and middle income countries. So those randomised control trials have suggested around about a 40% reduction in the risk of mortalities arising from kangaroo mother care for the small infant. So what is kangaroo mother care? If you've never heard of a kangaroo before, perhaps this term requires a little bit of explanation. A kangaroo is an animal who is found in Australia only. A newborn baby kangaroo called a joey is very immature at birth and very small in size, so it isn't yet ready to withstand life outside the mother's body. The mother kangaroo's pouch provides warmth, safety and a constant supply of milk to the joey. Similar to kangaroo mother care, given that the human infant is also immature, especially the low birth weight baby, can benefit from this kind of skin-to-skin care because it provides it with warmth, with safety and also with. So during your training, you will hopefully get a chance to demonstrate and practice on each other how to position a small baby on the mother's chest. You can also watch the video that is provided in the multimedia training resources. The baby is positioned on the mother's chest directly in skin-to-skin contact, with the baby's head resting to one side. The baby is then attached securely with a cloth, ensuring that the head is covered, typically with a hat, and that the baby is able to breathe easily. Importantly, the mother should be able to see and able to regularly check that the baby is breathing well. The mother can then dress with loose clothing over the top of the baby. Kangaroo care is not a one-off event. The baby needs to be kept like this for 24 hours a day until they are stabilised and they are gaining weight. The mother can share the role with a father and with mother-in-law or granny or any other household members, and she can even sleep in this position, giving some support for her back to make sure that she does not roll over onto her side. Assessing the newborn for danger signs should happen at visit 5A, B and C. This is in contrast to most home visits where the family is only counselled and asked about danger signs. In this case, what we're asking the village health worker to do is actually to conduct an assessment of the baby during the home visit to help the family identify signs. And that's a kind of teaching approach as well. So as the family observe what the village health worker is doing and as she talks through what she's doing, the family will be learning about what signs to look for. Remember that any newborn danger sign whatsoever should be considered a medical emergency, which is referred immediately to a facility. At the very first sign of any warning signs for the newborn, they can rapidly progress to becoming extremely serious. So even a delay of an hour can cause very serious problems. If the mother or father or any other family member suspects any danger sign in the newborn, they need to refer immediately. These danger signs include a child being lethargic or unusually sleepy or non-responsive, unable to breastfeed, suffering from fits or convulsions, whether that's large bodily strange movements or even just quivering motions of the hand or face, chest indrawing or fast or noisy difficult breathing, skin too hot or skin too cold, pustules on the skin, and redness or wetness in appearance or foul smell of the umbilical cord, and also jaundice, which can be checked by pressing the skin of the nose or the feet in daylight. The videos are provided because they are very good for identifying what these signs are. Newborn signs are really difficult to identify. For this reason, the village health workers need to have a very good understanding and recognition of these signs in practice. A good alternative to having videos could be to provide practicum experience in a clinic that handles newborns. Now let's look at the structure of the household visits and how this will fit into the whole system. You might find it useful to flick through the contents of your module whilst reviewing them. Okay. The first time that newborn care is addressed is actually in late pregnancy. So during visit 4, which happens between 8 and 9 months, so as the mother is preparing for facility birth, you'll start the visit by reviewing the practices from the previous visit, so visit 3. We'll also look at the stories that relate to the issues of late pregnancy, preparing for birth and newborn care. And it covers these important topics, so danger signs for the mother in labour and delivery, immediate essential newborn care in the first hour of life, and the very important steps in the promotion of early initiation of exclusive breastfeeding that would also happen in the first hour of life. Also, it's going to cover the topic of hand washing, and that should be for all the household members, making sure that everybody understands that should be nobody touching the newborn baby who has not washed their hands, and including any visitors. So in your session we will talk about the danger signs during labour and birth. So mothers should be aware that no movement or reduced movements of the baby for at least 24 hours should be referred. When the mother experiences her waters breaking without any labour commencing. Any sign of bleeding before the birth, during the labour, is going to be a serious problem. And too much bleeding after the birth as well. Any fevers or chills, high temperature should be referred. Labour that has gone on for 12 hours or more, and fits or loss of consciousness of the mother, which indicate a very serious hypertension problem. There are 4 key ideas that we're promoting about essential immediate newborn care after the birth. So that's warmth, breathing, hygiene, and breastfeeding. In terms of immediate essential newborn care sequence, we do teach this to village health workers, not because we wish to encourage any home births, but because in the incident that a home birth does happen by accident, or if somebody goes into labour very, very quickly, then we just like to teach them how those 4 principles are maintained in the immediate newborn care sequence. So starting with number 1, the room should be warm. All attendants should have clean hands, cleaned with soap. And as soon as the baby is born, it needs to be dried, fully dried as it exits the birth canal. The clinic attendant will make sure that the baby's nose and mouth is clear and the baby is able to breathe through stimulation, and the baby is immediately put into skin-to-skin contact with the mother and then covered with a clean and dry towel or blanket. And then hat or cap and socks and gloves are typically put on the baby, which will help them to stay warm. The cord is clamped after a few minutes, waiting for the umbilical cord itself to stop pulsing. And this is really important because some amount of blood will be travelling into the baby's body. And if we cut that cord too soon, the baby can experience some anemia. The baby will be put to the breast, and we will talk in more details about this when you come to this topic, and you'll look at the breast crawl. So we like to promote a natural stimulation of early exclusive breastfeeding, which means that the baby will be given an opportunity to naturally identify and crawl to the breast, which we'll see some videos of later on. And then throughout that first day, keeping the baby warm, keeping the contact with the mother, but also rubbing the baby to make sure that they can breathe and they have good circulation. And there should be no bathing of the baby on the first day whatsoever. There's a great video which is the immediate care after the birth. This is really directed towards midwives and does contain graphic images of a person giving birth. However, if village health workers have never assisted a delivery before, it is quite helpful just to understand the sequence and how it happens, and also to see that birth itself happens very, very quickly. Okay, so visits 5A, B and C should all take place in the first week of life. And the first visit should be done as soon as possible after the mother has returned from the hospital. So the topics covered here are essential newborn care in the first week of life, caring for the mother after giving birth, how to establish exclusive breastfeeding, and also troubleshooting any of those early initiation problems that mothers may have, how to promote early child development from birth, and also how to assess for danger signs in the newborn and support any vulnerable babies. Here's the sequence of the household visit. So the extended visit, visit 5A, typically takes about an hour and a half to do. So we start by the typical sequence, so identifying the family members and making sure that everybody is there that should be. And then also inquiring about the mother, looking for danger signs, any signs of emotional distress, etc. Then we have to do a sort of more in-depth assessment, so starting with mum, understanding her birth story and letting us know if there were any complications that she experienced, any tears, any bleeding that might be causing her some ongoing complications now. And it's also important to remember that a complex delivery can be quite traumatic for the mother and can cause some stress. So ask her about how she's feeling, and do inquire specifically about the postnatal danger signs of bleeding, fever, abdominal pain, and any problems that she has with her breasts. Then you ask the mother about the baby's behaviour, how the baby is, are they feeding well, are the movements and crying normal to her, and have they noticed any danger signs. Before checking the baby, village health workers have to wash their hands. This is good practice. I wouldn't want village health workers to be doing that because it's important to demonstrate for the family the correct procedure. The assessment of the newborn will start from head and down to toe. So starting off looking at the movement of the child and crying. They can touch the palms of the baby's hands to check for reflexes and that there are no strange muscle tensions. And if the baby is crying nice and loud, etc. We can open up the baby's clothing and have a good look. So we need to do a full body assessment. So we'll look at the breathing of the baby. We'll then touch the baby's skin to check for skin temperature. If the village health worker has a thermometer, they can also take the baby's temperature at this time. They will be looking at the colour of the baby, so any signs of bluish tinge that might indicate asphyxia, and also checking for jaundice by touching the skin of the nose and the soles of the foot to look for any yellowish skin. We'll be looking all over the baby, but especially in the folds of the skin to identify any pustules, which are small fluid-filled sacs on the baby's skin. And then also to check at the eyes, is there any pus draining from the eyes. Look at the umbilical cord if necessary, to smell it as well, to look at the signs that we're looking for, so any redness of the cord, any wetness or any foul smell. If the village health workers have scales, they can also weigh the baby. So then after that we have our problem stories and positive stories, which focus on essential newborn care in the first week of life and breastfeeding. And then we will also present some additional technical information about breastfeeding problems and how mothers should resolve breastfeeding problems using techniques like expression of breast milk and improving positioning and attachment of the baby. And then also we're going to cover danger signs so that the mother and other household members are able to do that. There are additional steps. So step 5, we're going to do an observation of the breastfeed and provide any assistance in correcting poor position or poor attachment. And then we need to check the immunisation card and make sure that we refer anyone who's missed their immunisations and refer all home deliveries. If the baby is HIV exposed, so the mother is HIV positive, we need to make sure that the baby has started their medications. If not, make a referral back to the clinic as soon as possible. So when you turn to your book, you will see the step-by-step instructions of how to do that newborn assessment, which I've just described in brief. And we will ask you to do this using the dolls provided so that we can, during your practicum, we can actually assess your skills in doing this. For special care of the small baby, obviously if it's been a birth that happened at home, we're going to need to refer them urgently. These are the additional actions that should be done for any small baby that's being cared for in the community, even if they're having facility-based support. So the first one is that mothers should be doing kangaroo care, so skin to skin, front of the chest, wrapping of the baby. For those small babies, there needs to be extra special care for hygiene, so additional hand washing, make sure that the baby is clean, make sure that the mother is clean, and make sure that all clothing and nappies are routinely washed and changed. In terms of feeding, it can be very difficult to feed the newborn baby, and the mother will need to express breast milk as much as possible. In the facility, lactation consultants and nurses will be qualified to support her to extract that and to cup feed the baby if it's unable to suckle. Extra warmth, so there should always be an additional layer of clothing as shown in the picture here. Make sure that baby's hands and feet and head are constantly covered. Monitoring, the village health worker will need to set up a responsive care strategy, which will mean in the first week of life probably daily visits. However, depending on when the small newborn is discharged from the facility, they should provide a counter-referral note indicating how frequently the small baby should be visited. Now, premature newborns need extra loving care and play interactions, and that's why kangaroo skin-to-skin care is so good for the newborn baby. So encourage the mother to talk and touch and stroke and kiss the newborn as much as possible, as well as maintaining that skin-to-skin contact. So visit 6 happens for the 1-month-old baby, and this is focusing on looking forward towards the next few months and identifying those danger signs that present in children from 1 month of age onwards. So our focus here is going to be on care seeking for fever and acute respiratory illness, which are the major killers of children from the age of 1 month to 59 months. We've got some special attention to those HIV exposed infants. There's a very important appointment that happens at 6 weeks. And then the routine care of the 1-month-old child, so making sure that the mother is accessing the postnatal services and the vaccination and growth monitoring services that she should have received. Let's check that the mother has registered the birth formally, and also coming back to the main point of early child development and play. So for the baby, we've got the key messages are care seeking for fever and ARI, breastfeeding, vaccinations, growth monitoring, play and communication, and birth registration. And for the mother, second postnatal checkup and making sure that she has started taking her family planning method. In terms of early child development, it should be quite familiar to you by now, as we've talked about this HTSPR message, hug, talk, sing, play, read. But we are going to be addressing that message to both the mothers and the fathers and making sure that they both take time out of their day to do these activities with their 1 month. For HIV exposed infants, there are a large number of these infants in Lesotho, and we have as much as possible integrated PMTCT and care of the HIV exposed child in your materials. So the infant needs to go for early testing as soon as possible. The infant should have cotrimoxazole prophylaxis, and also be taking ARVs prophylactically from birth. There could be interactions or complications between HIV and TB in the mother. If the mother does have co-infection with tuberculosis, there needs to be some special care, special attention for the baby to make sure that they have prophylaxis as well. It's important for all children, but especially for HIV exposed infants, to be exclusively breastfed as long as the mother is taking antiretroviral medication consistently. And then in terms of the HIV positive children, so as soon as a child is identified as HIV positive, they should start their ARV medication. So what we'd like you to do is practice in groups the visit A, which is visit 5A, and do that from start to finish. You can break up into groups of around 6 people and have each participant play a different step in the sequence. Then use the TTC job aid to make sure you follow the steps of the household visit correctly, and observers can use the observation of a household visit form to follow the steps. Good luck, and I'll speak to you on the next session.